Awesome. Okay, well, welcome everyone to another webinar with Promises Behavioral Health University. We've been offering these free CE earning webinars since January, and we will be continuing to offer them for the rest of the year. We've had them on the fourth Friday of every month. August will be a little bit different. I'll speak to that in a moment. But we will continue to have them for the rest of the year. We're already planning next year. And what's been great is that through all of your evals, when we ask you, what's something you're interested in learning about for other topics, like that's the data we're using to create our plans for 2025. So thank you all for always being so thorough in your evals. I read all of them, so thank you. So to get started for today, we have Jamise Gassaway. She's our Director of Clinical Compliance and Quality Assurance with Promises. She's going to be speaking to us about effective treatment planning for clinical and operational excellence. She has been with Promises for about 3 years, and she has over 25 years of leadership within the behavioral healthcare space. She's had a career dedicated to enhancing behavioral healthcare programs at both the corporate and clinical levels. She's been adept in leading clinical operations, regulatory compliance, and quality improvement initiatives. She has been instrumental in driving operational excellence and patient satisfaction in various behavioral healthcare organizations, very much including Promises. And she is our Director of Clinical Compliance and Quality Assurance, and plays a pivotal role in our facilities efforts to lead with clinical and ethical integrity. As you all know, we talk a lot about ethical and measure-based care here, trauma-informed care. Jamise is just another piece of that important puzzle. And so I'm really excited for you all to hear her training today. I think it's going to be a great one. Jamise, if you want to go to the next slide, I'll talk a bit more about Promises.
Sure.
Great. So as you all know, we have various residential and outpatient services across the country. We have 3 in Texas. Jamise is in Dallas right now. I'm actually in Houston, which means normally I talk to you all from the West Coast. I live in Oregon. So that's why I am so much friendlier and awake this morning, because I'm finally not on Pacific time. So that you're like, why is she talking so much more today? I've had more coffee. So welcome. And yes, so we have facilities in Florida, Georgia, North Carolina, Tennessee, Pennsylvania, Massachusetts, and Texas. Our flagship program at the Ranch, Tennessee is just outside of Nashville. And we've added the locations in Georgia and North Carolina most recently this year. So we're growing. We're looking for clinicians. We're always looking to grow our team. So if you have any interest, that PBHU at promises.com email. Would love to hear from anyone that is looking for a role in this great organization. So all of our programs are trauma-informed, measurement-based care. And as you all know, we take our clinical integrity very, very highly. So if you have any interest in learning more about a specific program, you can email PBHU at promises.com. You can email me, Callie.Boyer at promises.com, and I will sync you up with the right person on my team to talk to you more about our programs. Okay, I'll take the next slide. Okay, so to talk a little bit about our webinar procedures here, the chat box is for anything that you want to ask me about. If you're having questions about the CEs, which I will get to in a second, you can put those in there. If you're not sure your Wi-Fi is working, or if you have any questions outside of the webinar, those can go in the chat box and I will answer them. The Q&A, please just reserve that for questions regarding the content of the webinars, because I will be sending those questions directly to Jamise, and I don't want to get those in the noise of all of our other questions that go into the chat or comments that end up in the chat. So if you have anything specific about the webinar content, put them in the Q&A box. And we will have a break in the middle. So we'll have a 10-minute just like coffee water break, and then we'll also be doing some Q&A at the middle of the webinar and then at the end as well. So just keep those questions coming and I'll organize them as they come in. Good to go. Okay, our CE process. A lot of you that have already joined are doing great. You can only miss 10 minutes of the training. So stay till the end. Just know that it will be a 2-hour webinar and you can only miss 10 minutes. That's not my rule. That's the accreditation rule. We can lose our license if we get audited, and I don't adhere to that rule. So and also, it's important to note that you can't be sharing a computer with anyone. So if you are both logged in on one person's email address, or if you are sharing a computer with someone today, when you sign in for the webinar, when you joined today, it acted as the sign-in sheet. So if there's only 2 people on one sign-in, I can only give credit to one person. So make sure that you're on individual equipment, and that can be a phone, laptop, iPad, it doesn't really matter. After the training, you'll receive an email from JotForm with the survey. I have noticed that if you have a Yahoo or a Comcast email, they don't seem to like my JotForm emails. So if you do want to send me a note in the chat with the email that you need that to go to, just go ahead and do that now, and I can attach it to your eval when that comes in. So Yahoo and Comcast folks, just know you probably won't receive that JotForm email, and just send me a message if you need a different email added. And just always check for, no matter what your email address is, just check your spam folder. Sometimes those go to spam, especially if you haven't received a JotForm email before. If you've received one from me in the past, it should be totally fine. And I can only leave that survey open for a week. So next Friday, I will have to close it. So make sure you do that within the next week. And then once you receive the eval and you complete it, you will automatically get your certificate sent to you from JotForm. So again, check your spam if you didn't already see it, but you'll get your certificate pretty much automatically. So if you're not seeing it within 20 minutes, just send me an email and I'll make sure that, see if it didn't get stuck somewhere. Okay. Oh, and then slides and other resources. Jamise will send us like the top 5 slides that are the most important. That will give us a comprehensive overview of what today's webinar is about. So that will go out next week. And then with other resource materials that she mentions will all go out next week. So if you have any questions about that, all of our information on like the next webinars, resources, that will come out Monday or Tuesday next week. Next slide. Awesome. Okay, so upcoming trainings. We have a training August 16th, which is a little different than our normal 4th Friday of the month. So in 2 weeks, we have our next webinar, relational work and treatment using the self in clinical space. Dr. Gwen Swift is such a sweetheart. She's a dream. I've been working with her for quite a while, and she is truly so passionate about our family services that we offer with Promises Behavioral Health. If you all remember the presentation from Wendy a few weeks ago, Wendy and Gwen work side by side in what they do for our family services program. So definitely come and see Gwen in 2 weeks. That's going to be a great webinar. And then our leader, Trish, always great. She's back in September for the ethics of well-being. So I never want to miss a Trish webinar. Next up, and I will send the links to both those registrations in the chat once I'm done chatting, and I'll send those out so you all can register early if you're interested. And then, oh, I'm done. I will pass.
You're done.
Denise, look at that.
All right. Well, thank you so much, Callie.
Yeah, thanks.
Happy Monday. We don't want it to be Monday again. Happy Friday. So glad to be here with you guys this morning. Thank you so much for joining us for this webinar on this early Friday morning. And once again, Callie, thank you for the wonderful introduction. As Callie announced, I'm Jamise Gassaway, Director of Clinical Compliance and Quality Assurance here at Promises. And I've been a part of this wonderful team here at Promises for about 3 years now. I've been in this particular role for approximately 2 years now. And I must really say I'm truly blessed to be able to do what I do. Via my 25, 26 years of experience in the behavioral health field, I've seen quite a bit. I've had the opportunity to be on different ends of the behavioral health field, provided direct clinical care as a counselor, direct clinical roles, facility leadership roles, corporate leadership roles as well. I've been involved with state-funded facilities, private paid facilities, different levels of care, inpatient, detox, residential. Also the MAT world. In fact, before coming to Promises, I spent 14 years in the MAT world and actually learned a lot there as well. In addition, I've been at hospitals for a few years, prisons for a few years, halfway houses, and even spent a little bit of time with geriatrics. So I feel really, really blessed to have had the opportunity to impact so many different lives on so many different levels, not only to include the patients in which I've been able to provide services to, but also the staff members that I've had an opportunity to help develop and to learn from. So I can't see you guys this morning. That is really weird for me. It feels like I'm talking to myself. I'm used to being able to see you and interact with you. So if I'm going a little too fast, let Callie know and she'll let me know. If I'm going a little too slow, let me know. If I appear lost, then I probably am. And hopefully I'll find my way and get back on track and try not to bore you guys too much this morning. So first, we'll start with taking a look at our training objectives. And so by the time we are done with our discussion today, we hope that you will be able to understand the importance and the benefits of individualized treatment planning, that you will be able to describe the components of a treatment plan. When we're done, we hope that you will be able to understand the foundations of individualized treatment planning, implement strategies to develop good, solid, thorough, effective treatment plans. We also want you to understand how effective treatment plan contributes to clinical excellence, operational efficiency, and patient satisfaction. And then we'll wrap up with talking about how we can enhance the clinical outcomes of our patients through operational improvements that we decide to make in-house as it relates to our facilities, our workflow, and our processes. I almost said any questions, but it's not time for that yet. That's me being used to talking to an audience I can see and interact. All right. So first, we're going to simply begin with discussing and defining what a treatment plan is. I know you guys know what a treatment plan is. You do them probably every single day. But I did want us to start with talking about what it is and what it looks like to ensure that we are on the same page this morning as we get started. So as you see here, we need a strategy. We need a plan. We don't want to just jump on the road, not know where we're going, not turn on our GPS. We want to have an idea of where we're going. So a treatment plan is a written, comprehensive, and individualized intervention plan that incorporates specific treatment goals and objectives, detailing the treatment that is to be provided. It also details the expected outcome and the expected duration of the treatment that is prescribed by us, the healthcare professionals. This therapeutic strategy shall be designed in collaboration with the patient. So not for us to do by ourselves, not for us to figure out and plan on our own, but it is to be designed in collaboration with our patients. We definitely want their feedback. We definitely want to do this with them and not for them. So why is it important that these plans be individualized? You see here, my friend is explaining to us that I'm a very unique individual. So why is it important that these carefully developed intervention plans, these comprehensive roadmaps, also known as treatment plan, why is it so important that they differ from patient to patient? What's the benefit of them being individualized? So while individuals in similar circumstances with similar issues may have similar treatment plans, it's very important for us to understand that it is best clinical practice that each treatment plan is unique. As my friend here states, no two people have exactly the same experiences. And so therefore, no two treatment plans should be exactly the same. Even when we have identical diagnoses, even when we have similar individuals, there should be some differences that I'm sure are going to manifest through the different treatment plan components. And we will talk about those treatment plan components shortly. And so we'll talk about where those differences come into play. So still on why individualizing treatment plans. As you guys know, I know I'm talking to a room full of professionals here. Individualized treatment plans are widely recognized as being more effective than a one-size-fits-all plans for several different reasons. And some of those important benefits include the following, and we have them here on the slide. Better outcomes. We just generally see better outcomes when those plans are unique, when they are specified, when they are individualized. There's been a lot of research and many of studies that have shown that individualized treatment plans that are tailored to meet the unique needs and preferences of each patient lead to improved outcomes and basically just increase overall patient satisfaction. And noted that I also stated preferences because I found in my many years of experience that what I want the client to work on may not always be what the client wants to work on. I may think that a client may need to jump into something right now, and that client may put me in my place and tell me, no, I'm not working on that right now. I want to work on that later. So sometimes we find ourselves deferring things, or sometimes we find ourselves focusing more on an area in which the client prefers to. It just depends on that individual client, and of course, the particular treatment setting and level of care in which we find ourselves. Increased engagement is another important benefit of individualized treatment planning. We've found that when individuals actively take part in creating their plan, then they're more likely to be engaged. If I feel like my input mattered, if I feel like the provider really listened to me and really cared about my input and what I stated, then I'm pretty much gonna feel more a part of the plan and I'm gonna want to be more engaged. This will lead to better treatment adherence and again, better outcomes. We also have flexibility listed here. These individualized plans can adapt to changing needs. So as the client goes up and down in treatment, as they improve or as they may regress, then we'll want to make sure that we're updating that treatment plan. And so if it begins being individualized, then I have the flexibility to change that plan based on the patient's needs. And then last, but definitely not least here, we have empowerment listed. Customized plans empower individuals to once again take ownership of their treatment journey. As we know, empowerment can boost self-esteem and confidence, which both are very crucial factors as it relates to positive treatment outcomes. All right, so I'll move on to the next slide. Although there's no one-size-fits-all approach to creating a treatment plan, there are several key components that actually make up an effective treatment plan. And so when we talk about key components, we're talking about different portions of the treatment plan, um, different segments of information that need to be included on the treatment plan. And so we first start with speaking about the problem. Problems are usually derived from the completion of clinical assessments with the patient. This could be your biopsychosocial assessment. This could be your health and your physical, health and physical. This could be a nurse's admission assessment or a psychiatric assessment, any types of assessments that are completed with patients. This is where we get our problems from. They are added as necessary as they are revealed throughout the patient's course of treatment. And so when developing these problems, we want to be sure that we ask ourselves several different questions. Are they written in behavioral terms? So how are we documenting, how are we writing the problem on the treatment plan? Are they written in non-judgmental and jargon-free manner? So we want to make sure that we're not using clinical terms, that we're not using acronyms, that the client has no idea what they are. We want to make sure that it's written simple, easy language that the client can understand. Because we want to keep in mind that the treatment plan is for the client, for the patient, for the client. You'll hear me use those words interchangeably. It's not for us. So we want to make sure that we write it so that the patient is able to access it, that the patient is able to understand it, use it as a guide, and knows exactly what it says and what it means. Also, we want to ask ourselves, are these problems based on priority needs? Are they based on the needs of the client? Are they based on my needs? Are they based on what I want the client to work on? Or are they based on what information I'm actually assessing and getting from the client? Excuse me, I've got a few different screens here, so you may see me looking from one to the other. The next component we speak of are our goals. A treatment goal is a general statement of what the patient wishes to accomplish during their treatment journey. Goals focus on new and healthy behaviors that the patient is working on learning and implementing. Goals are often considered the building blocks of the treatment plan, and they should be specific, measurable, realistic, and customized for the patient. So now we're speaking of SMART goals, and we'll talk about that a little more as well. So just as with the problem, we also have questions that we want to ask ourselves when we're writing the plan. When we're writing the goal to make sure that it makes sense for the client. Do the goals address problem statements? In other words, do they relate? I don't want to have goals that don't have anything to do with the problem. So do the goals address the problem statement? Are they attainable during the active treatment phase? We don't want to set our client up for failure, and we don't want them to feel as if their treatment plan is not attainable. So is this goal something that the patient or client is going to be able to attain during their active treatment episode with us? Would the patient be able to understand them as written, just as we stated with the problem? Is the goal clear? Does the goal tell the patient exactly what it is that they're going to do? Exactly what it is that they've said that they want to achieve? Would the patient and the provider find the goal both acceptable? Once again, am I writing this goal for me, or am I writing this goal collaboratively with the patient for the patient? Has the patient's stage of readiness to make any changes been considered in the development of the goal? So have I assessed the patient's stage of change, their desire to change, and does the goal correlate with their stage and desire to change? We want to make sure they match. It doesn't make sense for us to write a goal that totally goes against where the client is currently as it relates to his or her ability or desire to make any changes. So now we will move into objectives. So while the goals were larger, more broader outcomes in which the provider and patient are working toward, when developing our objectives, we want to consider them as smaller, more specific steps or skills that a patient must learn or do to reach the related goal. So the goal, broader, more of a higher level achievement. Objective, very specific, very precise. So the objectives, we want to make sure this includes small steps, small things that the patient is going to do in order to achieve the higher level, broader goal. Our objectives are measurable and they give the patient very clear directions on what to do. So once again, once I print out this treatment plan and I give it to my patient, it should be a roadmap. It should be a guide. He or she should be able to look at this plan and tell exactly what it is that they need to do, when, where, and how, and also know exactly what I, the provider, am going to do, when, where, and how. And we'll talk about that later when we get to the interventions. So a few questions we want to ask ourselves regarding objectives when we're assisting with developing those. Do they address the goal? And again, has the patient's stage of readiness to make any changes been considered in development of objectives? So just as we wanted to know, do our goals address and link with the problem? Now we're asking ourselves, do our objections link and correlate with the goal? And once again, when looking at the objectives, which are those precise small steps, have we assessed the patient's readiness and willingness to change when we're helping with developing the objectives, the small steps that he or she is going to take in order to achieve the goal? Next, we talk about interventions. So the interventions include various techniques, strategies, actions that the team, that would be us, the providers, that the professionals are going to take to assist the client in reaching his goals. So the objectives, they're what the client is going to do. The interventions, they're what the staff members, what we're going to do to assist the patient in reaching their objectives and goals. Just as the objectives were measurable, we want to make sure our interventions are also specific and measurable, and that they also relate to the objective and the goal. So when developing those interventions, we want to ask ourselves the same questions. Do the interventions address the objectives? Do they relate? And has the patient's stage of readiness been considered in development of the interventions? Another component that is listed on the treatment plan is the diagnoses. So our plan should contain the clinical diagnoses that's been made by the healthcare professionals. And of course, this diagnosis is based on the evaluations and the assessments that have been completed with the patient. The treatment plan will also contain frequencies and target dates. And so this includes a cadence. And this cadence relates to the objectives and the interventions, the timelines of when things are going to be completed, when things are going to be achieved, and this is to help us track progress. Strengths will also be included on the treatment plan, and even some treatment plans, strengths and liabilities. Our treatment plans here at Promises, we include both strengths and liabilities, but then we also take the strengths and include those in our problem statements so that we can show that we're trying to make the treatment plan strength-based. So trying to include, we'll take those strengths and include them in our goals so that we can show that our goals are developed based on strengths that the client has identified. So throughout the plan, providers often include information about perceived strengths and resources that the patient has. As we know, helping our patients identify their strengths is very empowering, and it assists the patient with tapping into how they can use those strengths to help them achieve their goals. And last but not least, here we have progress and outcomes mentioned. So documenting progress toward goals is considered one of the most important aspects of treatment planning. Usually progress and outcomes are documented below under each goal as a part of the treatment plan review. So for example, if you have a protocol in place at your facility where maybe you have treatment team meetings every week, and maybe during these treatment team meetings, that's also where you're using that particular time to update the treatment plan. So this is where we would expect to see progress and outcomes as a part of those treatment plan updates. We'll also find that this portion of the treatment plan often intersects with clinical note documentation that you're doing as well. All right, we're going to move on to our next slide, which is where we specifically talk about SMART and what that looks like. So we've talked about our goals, our objectives, and our interventions. And on this slide, we want to talk about how important it is for all three of those to be SMART, specific, measurable, attainable, realistic, and time-oriented. So on this particular slide, we have a checklist, and this can definitely be one of those 5 slides that Callie spoke of that we send you guys in the recap next week. But here we have a checklist of additional questions that we want to make sure that we ask ourselves to ensure that these goals, objectives, and interventions are SMART. So when we're looking at the goals and objectives and we start with specific, we want to know, are specific activities included? You'll hear me repeat myself a lot during this presentation today. So please forgive me, but that is a way of just making sure that we continue to go back to the basics and see how things link from one area to the next. So once again, can the patient understand what is expected? I'm saying this a lot to you, but I also say this a lot to our team here. As a part of my job here at Promises, I'm doing monthly audits, and treatment plan audits are a big portion of what I do. So I'm constantly saying, okay, if you were the patient and I printed this treatment plan and gave it to you and you read it, would you have a question about what this particular objective means? And if you do, then I guarantee you the patient will as well. So we want to make sure that we have clarity here. Well, I know exactly what I need to do, exactly what is expected. Can change or progress toward meeting the objectives be documented and evaluated? So here we're talking about measurable. When I read this particular goal and objective, does it sound like something that I can easily measure? Does it sound like something that I can say, yes, the patient completed it, they achieved it? No, they didn't. Is it easy for me to measure as to whether or not it was achieved or done? Can the patient take steps toward meeting the goals and objectives? Is it attainable? If I have 2 weeks with the client, I want to make sure that my treatment plan reflects 2 weeks and that it doesn't have goals and objectives on the plan that's going to take the patient more like 3 or 4 or 5 weeks to attain. So is it attainable? So I really want to challenge you here to think about your treatment plans. And if you have your patient, if you're in a residential facility, maybe you have your patient for 2 to 4 weeks. How many goals do you have on that treatment plan? Do you have 20 goals? Is it overbearing for the patient when he or she reads that treatment plan? Do they look at it and think, oh my God, how in the world am I going to accomplish all of this? Is it overwhelming? Does it increase their anxiety? Or is it something that's really concise? We have just a few goals because we want to make sure that this is something that the patient can really get done while they're here with us. Realistic. Given their current situation, is this something that the patient is able to do? Given where they are in their journey, given the resources that they have available to them, whatever their current situation is this realistic for them? So all of this plays into what we were speaking of when we started off, individualization. All treatment plans should not look the same because all patients do not have the same current situation. Is the time frame specified? Does the patient know when this has to be completed? What is the target date? What is the completion goal? And now looking at the interventions side, some of the exact same questions, but here they relate to the team members and to the staff. Remember, interventions are what the team, what the staff is going to do to help the client achieve the goal and objectives. So here we have our specific staff persons responsible for assisting patients and providing services. One thing that we're constantly assisting our team with here is making sure that that treatment plan is a multidisciplinary treatment plan. So it should not have only interventions that the therapist is going to do, but what is the doctor? What is the psychiatrist? What is the nurse? What is the tech team, the behavioral tech team? What are those disciplines, case manager, what are they going to do to also help the patient achieve their goals and objectives? So specifically, who is going to do what? What is the nurse going to do? What is the doctor going to do? What is the therapist going to do? What is the case manager going to do? Will the provider or treatment program be held accountable for the services? So once again, there should be measurable as well. How can we tell whether or not the doctor, nurse, therapist did this particular intervention? And do those interventions reflect the patient's level of care? Are we referencing outside referrals? Are those used when needed? Do the interventions reflect the level of functioning or functional impairments of the patient if they have any? And once again, is the time frame specified for the interventions? When will this be done? How often? By what date? So now we're moving on to the foundations of individualized treatment planning. So we've defined treatment plan. We've talked about the different components that make up a treatment plan, those different sections that you will see on the treatment plan. And so now we're looking at underlying bases or principles of individualized treatment planning. The first and most important, understanding our patients. I mean, think about it. We've got to know something about them. We've got to be able to understand them in order to be able to help them develop an effective plan for treatment. So that's where we're going to start. The foundation is understanding our patients and who they are. Getting to know the whole person behind the patient is one of the most important facets of patient-centered care. We can better understand our patients by incorporating strategies and techniques such as patient-centered care, the use of holistic assessments, incorporating their preferences and values into the treatment planning process, and then also by taking into account other things such as legal matters that they may have, ethical matters or ethical concerns, and cultural considerations, definitely taking all of those things into account during the treatment planning process. Truly comprehending our patients' values will allow us the opportunity to establish a therapeutic rapport with them. We want to earn their trust as their provider. They definitely need to be able to trust us. And also improving the treatment experience for them. Using a holistic assessment to ensure we understand our patient's psychiatric history, their medical history, family history, understanding all of that is paramount when it comes to treatment planning. Understanding how cultural differences will impact treatment concerns is also very necessary in order for us to be able to develop an effective treatment plan. and to provide quality care. The next foundation of individualized treatment planning here is evidence-based practice. And basically, we know that that means using practice that's backed by scientific evidence. So basically, we take that evidence, we take those practices, and when we as clinical providers combine well-researched interventions with our experience, ethics, and the patient's preferences, then we're using that to help provide evidence-based treatment. So the goal of using evidence-based practice is to ensure that we're using safe and effective treatment methods that are likely to achieve therapeutic results. And so when we talk about therapeutic, I'm sure all of you know what therapeutic is, but when we talk about therapeutic, we mean beneficial, curative, that it's going to help the patient, that it's going to move them toward healing, move them toward their recovery journey. So even though, and the reason why I point that out is because even though I may be using an intervention or a therapeutic model that's evidence-based, when making that specific to the client, is it the best intervention for their particular diagnoses or for their particular scenario? So even though I might be using interventions that are evidence-based, when we speak of individualization, is it the best intervention for this particular patient at this particular time? Or am I just using it as an intervention because this is the intervention that our facility uses with all patients? So this is where we keep tying everything that we do back to individualization. Evidence-based practices evolved from what was initially known as evidence-based medicine, which was established in 1992. And it was established for the same reasons, to encourage the use of safe, effective, and therapeutic medicine, as opposed to poorly studied or potentially harmful options. On this particular slide, I've included a link to a resource, and this resource is known as Evidence-Based Practice Resources, and it is a site that is hosted by SAMHSA. And so basically what it is a searchable library that includes mental health and substance abuse evidence-based programs and practices. So if you're not familiar with it, definitely go on the site, research, play around with it. A lot of good information there. And so I really love these types of resources where you can go and just filter. You can filter based on different diagnoses. You can filter based on, I also believe, different levels of care, but definitely take some time to explore this particular resource here. All right, we're gonna move on to the next slide here. And here we talk about strategies for effective treatment planning. And you see here, my girl is saying that hope is not a strategy, but we're going to talk about what it is that I need to do to ensure that my treatment plan is effective. What is it that I need to do to ensure that it is therapeutic to and for the patient? So what strategies? What are strategies that are effective, that lend to effective treatment planning? And the first strategy that we're going to speak of here is thorough assessment. We want to make sure that we conduct a thorough initial assessment to gather comprehensive information about the patient's medical history, their current symptoms, treatment history, psychological, family, and their social circumstances. Although we have specific initial assessments, I'm sure that we are all routinely doing that we are all routinely doing at the beginning of the patient's treatment episode. As clinicians, as providers, I'm sure each and every one of you here know that we are always assessing. So it doesn't just stop when we complete that biopsychosocial, that health and physical. We're constantly assessing throughout the client's treatment episode to see if there's anything that we need to change or update. Before I move on, I do want to take just a little bit of time to talk about a project that we recently did here at Promises. And we basically started from scratch with creating our own biopsychosocial. Um, Took a lot of time, but we realized that it really wasn't getting us where we wanted to be as far as thoroughness. And then we also realized that we didn't really like the language that was used on our biopsychosocial. And that's something that I find us doing quite often as we're constantly updating and reevaluating our forms. We're constantly paying attention to language that's used. And so one thing that we wanted to do, we wanted to make sure that the biopsychosocial felt as if we were having a discussion with the client, that it didn't feel like a Law and Order interview. Although I love Law and Order, I could watch it all day, every day, especially the older episodes. But although that's my favorite show, that's not what we want it to feel like when we're talking to our clients. So we went through and you're going to see me look at a different screen so I can kind of look a little more at that. We went through and we changed the language. We wanted it to definitely be trauma informed, which I'm sure you guys have heard that before, especially if you've attended some Promises sessions before. Basically keeping in mind of what our clients have been through when they come to us. We wanted to reduce redundancy. And so we're going to talk about that a little later during the second part of this session when we talk about workflows. We wanted to reduce things being everywhere on 5 different forms. So if we assess for something in another form, maybe we took that off the bio, or if we wanted to make sure that we assessed for that in the beginning stages of the patient's treatment, then we added that to the bio and maybe took it off the other form. We have an EMR that allows us to take information from one form to the other. And so that's something that we were very intuitive about when we were redoing our bio. How can this information flow from our bio to other forms? So if you have that type of ability where you can go and look at your forms and recreate, definitely take a look at your bio and see, are you getting the information that you need in order to be thorough in your treatment plans? Are you getting that info in your upfront assessments, whether that be a bio or nursing admission assessment? So we added different screens within the bio. We wanted to know more about trauma. So we took questions from different trauma screens and different trauma research that we saw and included that in the bio so that we could know specifically if the client had a high level of trauma, what that looked like. We incorporated our suicide assessment. We incorporated that within our bio as well. We took the CSSRS, the CS Columbia suicide screen and included that within our bio. We started asking questions based on what the client thinks. So, for example, have you ever felt that you have problems with mental health? Have family members ever told you that they feel you have problems with mental health? So also included a lot of those, how do you feel? We wanted to know triggers that the client has. We wanted to know that up front so that immediately we had information to help us to determine whether or not this client was going to be a risk for leaving treatment early, leaving ATA or AMA. So we asked questions about what are some things that you think that might happen here in the facility that may trigger you to want to leave? Well, you're going to take away my phone. That's a trigger. I'm going to have a roommate. I really don't like being in groups. Well, our residential treatment facilities are made up of groups. So knowing all of this information up front really helped us to um, be able to help with that individualized treatment planning, but also helped us to kind of get a jump start of some things that may be a barrier for this client in treatment. So one of my favorite questions is the question I was alluding to before. What are some things that might happen in treatment that could cause you to want to leave? But then what are some triggers outside that could happen that also may cause you to want to leave? So that was a really fun project that I was able to be a part of, but it really also helped me to look at things from the patient's perspective, um, as to information that they may consider important upfront that we currently don't get. It helped me to consider some things that may be really important from a patient perspective that also may need to go on that treatment plan upfront as well. As another part of assessing, we also want to make sure that we're using standardized diagnostic tools to ensure accurate diagnoses, blood test, imaging studies, but then also those other types of questionnaires that we use in the therapy world, Beck depression, or our generalized anxiety disorder, the GAD-7, or the PHQ-9 when we're looking at depression, or any other types of assessing screens, the mental status exam, substance use disorder screening. So all of those as well, having those done, those also help us with thorough assessing, gathering information that should be included on the treatment plan. So second, we're looking at strategies, things that we need to do and consider to make sure that our treatment plan is effective, make sure that it is individualized. We've kind of talked about this a little bit already, setting realistic and measurable goals. We talked about that when we referenced SMART. As I stated, the very last thing we want to do is for the patient to feel as if his or her treatment plan is a setup for failure. Therefore, we want to ensure that the goals are realistic and they're attainable for the patient. We want to ensure that the goals are verbalized and documented in a way that the patient can also easily see progress. It's so refreshing to be a part of a session where we bring the patient in and we're able to say, see, look, this is where you were this time last week. Look at where you are today. Are you able to see that progress? It's awesome to be able to see how excited they are to see, okay, I am doing something. I am changing. So making sure that we have that plan documented in a way where they can easily see their change in progress. And also to make sure as clinicians that we're making time to schedule those type of individual sessions. As I stated, I've been around for a while in the behavioral health field. And I know how for us as therapists, for us as clinicians, for us as providers, it can be very overwhelming. But making sure that we're taking the time to schedule those sessions where we're reviewing changes and progress with our patients, where we're pointing out to them, hey, this particular intervention seems to be working for you. Look at the progress you've made. Or this particular intervention doesn't seem to be working for you. So let's see if we can figure out something else. Interdisciplinary collaboration. We want to make sure that we're collaborating with other professionals, that we're collaborating with our coworkers, that we're working with the doctors and the nurses and the therapists and the case managers and any other necessary provider in order to create that holistic plan that addresses all the aspects of the patient's health. Are we having regular team meetings to ensure ongoing coordination, allowing the team the opportunity to discuss the patient's progress and make necessary updates and changes to the treatment plan? I know at some of our facilities, one of our biggest struggles is being able to find a time where a representative from each of the teams can be present. But it's so important because that treatment team is just not the same and not as effective as it could be if my medical person isn't there. If my doctor or if my nurse or some representative from the medical team isn't effective, that's going to leave a big gap in my treatment team meeting. So are we able to somehow find a time where we can connect and all get together on the same page to discuss progress and or lack thereof that we may be seeing as it pertains to our patients? Selecting appropriate interventions. I think I kind of skipped ahead a little bit earlier when I was speaking of, although I may be using an evidence-based intervention, is it really appropriate for this particular client and their unique need? We want to ensure that appropriate interventions are chosen, as always stated, based on the unique needs of the patient. This could include a combination of medications. This could include a combination of different talk therapy types, even lifestyle changes and other interventions. But as always, we want to make sure that these interventions have been proven to have a beneficial or curative effect for whatever condition or problem that we've identified. Fifth, involving the patient and significant others. I heard Callie talk about family services and Gwen and Wendy, who are an absolute value to Promises. And so if you've been involved on any other Promises webinar, you will know that this is one that we really push here. And some of our facilities are finding this to be hard, really making sure that our clients are trying to really making sure that our clients are bringing in somebody as a support, whether that be a family member or whether that be a pastor or a friend or a neighbor. Engaging the patient in discussions about their treatment options, ensuring that they understand the plan and that they are involved in setting goals and choosing interventions, including family and friends on the care team. All of that is so important to do. So we're all about including family and friends here. As a part of that biopsychosocial revamp, we included an area where we asked about support systems, but we wanted them to be able to list their support system and what type of support does this individual provide to you. So for example, my mom, I may feel like she's good with emotional support, but if I need financial support, then maybe I would need to call my aunt or my grandmother. So we actually added an additional session in the bio to talk about those support systems and different prompts within the bio to ask, hey, have you completed an ROI for this support? We mentioned mom as an emotional support. Do we have an ROI? So prompts in our biopsychosocial to ask for releases of information. And if the client refused to sign one at that time, making notes, but then also putting it in other documents as a prompt. Well, we didn't want to sign an ROI for mom when we came in, but how do we feel about including mom now? Has anything changed? So we're conditioning our team to always follow up, always follow up. The patient may say no on day 1, but they may say yes on day 14, or they may say yes on day 12. So we're not just dropping it on day 1 if the patient is not forward, because as we know, our patients heal better when they have support. We want to provide information to the patient and significant other about the patient's condition, treatment options, and what to expect. And as you guys know, we can only do this with the patient's consent. But that's why we constantly have those prompts. Hey, have you signed a consent for this person? Even when we get to the legal portion of our biopsychosocial, That's a prompt. Hey, have you signed an ROI for your PO? Because we know that a PO, a probation officer or a parole officer, can also be of support to the patient. So thinking of little things like that where we're constantly coming at the patient in kind ways, kind but assertive ways. Hey, what about this person? I heard you mention that they were support here, or I heard you mention that you have a close relationship with sister. Do we have an ROI? When we were talking about our family services, Gwen and Wendy, they also have webinars that the families or significant others of patients can attend. So even if I'm a patient and I'm like, no, I'm not signing an ROI today, I don't care what you say. We have worked in a workflow, um, whereas maybe if the family member doesn't want to come to family sessions, they can still log on to Promises webinars and just get information about recovery, about treatment, and what that looks like, and what family involvement looks like. All right, guys, we're going to go to the next screen here. Here we talk about continuous monitoring and adjustment. So we want to, just as I stated, that we're continuously assessing. We're continuously assessing and monitoring to see if maybe we should make some adjustments. So schedule regular follow-up appointments to monitor the patient's progress and make any necessary adjustments. Use measurable indicators, outcome measurement tools to track the effectiveness of treatment and the patient's progress toward their goals. So another revamp that we've made, and this is a part of our quality assurance program, but this is also a part of our auditing, and this is just a part of our quality assurance process as it relates to treatment. We have set cadences in which we're continuously completing outcome measurement tools with our patients. So for example, upon admission, maybe we're completing the GAD-7 and the PHQ-9 to assess for anxiety and depression. We're also completing a BAM to find out what those risk levels are, to find out what those the use levels are. And then we're also completing a PCL-5, which is going to look at what their trauma level is. The BAM is also looking at protective factors as well, risk, protective factors, and use. So let's say, for example, our cadence, if you're in residential, we're completing the GAD and that PHQ-9 every so many days, every 7 or 8 days. And this is a way for us to look at those outcomes to see what's changing. Are our numbers going up or are our numbers going down? If we're completing that BAM at a cadence, this is a way for us to see, okay, based on the interventions that we're providing, are our patients' risk levels going up? Are the risk levels going down? Are the protective factors on the BAM going up? Are they going down? So these are ways to look at the patient's progress and then to see if we need to go back to that treatment plan and change it and update it and individualize it even more based on symptoms that we're seeing, based on the numbers that we're also seeing on those outcome measurement tools. So another way to track effectiveness of the treatment plan and to also track the patient's progress toward their goals. Regularly reassess the patient's condition and progress. Be prepared to modify the treatment plan based on the patient's response to treatment and any new information that may emerge. We want to make sure that we identify and address any barriers that may come in the way of their progress. And this may even include things such as side effects of medicines. This may include things even such as lack of support or maybe even any new health issues or any other new issues that have arisen during their time in treatment. So we have talked about, we've defined treatment plan. We've talked about the components of a treatment plan, basically what makes up a good, effective treatment plan. We've talked about the foundations of developing a good treatment plan, knowing my client, understanding my client, and using evidence-based programs and treatment. And then we've also talked about 6 different strategies that we need to do to make sure that our treatment plan is effective. So we are now at break time. I want to thank you for your time and attention thus far. And Callie, before we actually go on to break, I'm sorry, let's go ahead and allow some time for questions based on what we've already shared and discussed.
Do you want me to read those to you, or I think I sent them all to you that I've seen so far.
Did you? Okay, let me go ahead and look and see what I have. I work for a substance use treatment facility that has problems, objectives, and interventions already in the system that we choose from. Should we be adjusting that for each client as far as changing what each one says? Definitely. Yes, yes, yes. So our EMR has that as well. In fact, we're getting ready to undertake an assignment where we want to add some stuff. We don't really like the stuff that's in there. And so we're going to go in and kind of put our own twist and flavor. But the way our EMR has it now, certain things are there, but you can change it. You can tweak what's there, or you can totally delete what's there in free form. So I would suggest you definitely do the same thing. I don't mind using what's there as long as a base, as long as we take it and we alter it and we make it specific to the client. So yes, change, alter what's there if you want to use that as a base, or if it doesn't make sense to this particular client, totally scrap it and go free text based on what you and the client have discussed in session. Can Ms. Jamise give examples of problems and goals within the treatment plan components? So actually, if you'd like, when we come back from break, I actually have a desktop reference that we created for our clinicians because they wanted examples as well. So I can find that while we're on break and pull that up and share that with you if you'd like. And it's just a page of different examples where myself and another colleague have gone in and just kind of written some thorough examples as to what a thorough goal might looks like, or a thorough objective. So I can find that while we're on break, and we can begin a session, the next part, with reviewing that tool. Can Ms. Jamise share an example of a holistic assessment, please? I talked about our bio. Did that answer the question, or is that something we might want to look at as well? I don't know if talking about the bio answered it, or do we feel like we need some additional information? But I can actually share that too when we get back if you'd like. Just kind of show it on screen and we run through it.
Yeah, I'll just add, I think you'll see a lot of the questions I sent over are, yeah, assessment examples, resources, and I made a note of all the resources that people are requesting, so we'll make sure we get those examples put into the follow-up email next week.
Someone did ask to see some of the bio. So yes, I'll definitely pull that up. One of the comments earlier mentioned pre-populated items. I struggle with the same thing. And further, the language at times does not seem client-friendly. Looking at adjusting what is pre-populated to make it more personal while at the same time meeting goals. Awesome. That's exactly what we did. How can treatment planning be adapted for working with minors? That's a really good question. Would you work on it with the caregiver or make it understandable for the client? I would definitely make it understandable for the client, but also work on it with caregivers. This goes back to what we talked about, pulling in the significant others as a part of the care team. So if this is a minor, kind of depending on exactly what field you're in, the caregiver, if the caregiver is going to have to do something to make this treatment plan actually come to fruition, then we definitely want their input as well. Can you say again how often you are repeating the GAD? Okay, so it's different per levels of care. So I got to think. So we're not doing the outcome measurement tools in our detox level of care at all for several different reasons. One of our facilities tried it as just an experiment. And for example, they found their PCL level, which is the stress was way off the way off the scale. So they're like, okay, this is not working. And then we also found that when we're in detox, for one, it's really, really hard to get a baseline. They're in detox, they're on a lot of medications. And then a lot of those detox symptoms, a lot of those pause symptoms look just like the anxiety and depression. So we decided not to do them at all in detox. For our residential level of care, we're doing the PHQ-9 and the GAD-7 upon, for our residential level of care, we're doing the PHQ-9, the GAD-7, the PCL, and the BAM upon admission. And then we're doing the GAD-7 and the PHQ-9 every 7 days in residential. For IOP, everything upon admission, and then PHQ-9 and GAD-7 every 10 days. I'm sorry, every 14 days in IOP. Every 14 days in IOP. For PHP, every 10 days. So I hope I didn't confuse you. If I did, let Kelly know, and I'll repeat. Would you consider interventions like integrative practices like breath work, somatic practice, yoga, meditation as evidence-based, or only traditional psychological interventions like CBT, DBT? No, we do breath work all the time. So definitely that's one that we use. We also do the yoga and the meditation. So these are all examples of interventions that we use as well, along with the talk therapy, CBT, DBT. Yeah, our curriculum, we recently started a new curriculum that has a lot of breath work, box breathing that we're teaching. And so we actually incorporate those skills into the treatment plan as well. So for example, if I'm dealing with anxiety, then box breathing 3 times a day may be a part of one of my objectives that I'm doing. So yes, definitely. Great questions, team. Awesome, awesome. So we can go ahead and break, Kelly, and I will pull those documents up and we'll start off with those when we come back.
Great. You want to say 5 or 10?
Um, let's do 5 since we're going to take a look at those documents as well, so that we can also have time for a few questions at the end.
Okay, great. We'll see you all back in just 5 minutes.
All right, thank you. All right, guys. Kelly, I don't know if we can tell if almost everyone's back.
Oh yeah, I think we're good to go.
All right. Okay, guys. So first, I'm going to pull this document over and share it. Can you guys see it? It's titled Treatment Planning Resource. Awesome. So this is a resource that myself and another colleague on our quality team just kind of put together because we were getting some of the same questions. Um, My 26 plus years of experience in behavioral health treatment plan just continues to be one of the hardest things to get. It is definitely one of the weaker areas for us here at Promises for our team as well. Just getting the treatment plans down, the way we really want them, getting the wording, getting the language down. And every time we have a Joint Commission accreditation inspection, I can guarantee you we're going to get a citing from the Joint Commission in our treatment plan area. Um, so we kind of put here some of the same information that we just shared in the training. We talked about what a goal looks like, what an objective looks like, what an intervention looks like, the goal being that hierarchy, a general statement, the objective being very specific, what the client is going to do, the intervention also being very specific, what the staff member is going to do or the team. And then we talked about what a progress update or statement might look like. Um, Here we talked about some skills that we might want to target on the treatment plan, calming skills, energizing skills, focusing skills. And then we started giving some examples of what a goal and what an objective may look like. So a goal, Chris will implement a skills plan that promotes improved behavior in calming or whatever that skill may be. And then some examples of some very measurable objectives. Chris will reduce his GAD-7 score from a 19 to a 14. Chris will make a list of 5 skills he learned the last week from the curriculum. Chris will identify when to use each skill. So for example, we get a lot of complaints about our med line being quite anxiety provoking for our patients. It takes a long time to get my meds. I have to stand in line forever. So if we have a client who's experiencing anxiety and the med line is just his trigger, this might be a way to work in. I will use box breathing when I'm at the medication line. Chris will practice these skills during what times of the day to reduce behaviors. Chris will practice daily, write in the specific skill that he's going to practice, and will monitor his progress in and out of sessions. And then we even included some interventions. The therapist will provide psychoeducation on skill building, connect with Chris in 2 days, monitor progress through the use of the outcome assessments and assess weekly. So that's just one example that we have here. Here we have a client that has a history of ATA and AMA. And so we've got some objectives here that we may want to make sure that we include initially in that treatment plan. And so this also goes to what processes do we have in place for reviewing information about clients' prior episodes? When were they with us before? How long were they with us before? This also relates to, as I stated, getting some of that information up front on that bio about what may be a trigger for the client. This is a good example and a good time when to actually implement those if we're going to address in the history of ATA, AMA on the treatment plan. When noticing, so an objective may be when noticing signs of wanting to leave, Chris will do what? Here we're using the sensate, using 2 ice cubes to hold as one of our distraction interventions. Taking a brisk walk, participating in outcome assessments. Here we talk about goals for group attendance, and we have some examples of objectives. And so we just have a few pages of those different goals, different examples of goals and objectives that relate to those goals. Taking medication as prescribed. So maybe medication is an issue. Maybe the client doesn't present to the med window. Or if I'm outpatient, if I'm working in outpatient and I have a client who I know is not being med compliant, but he or she has shared that in our outpatient therapy sessions, I can add that to the treatment plan as well. Establish a routine for taking his medication on time. Maybe we have somebody that's not getting along well with friends. Chris will interact with peers in a pro-social and safe manner, refraining from verbal or physical altercations. Use of positive communication skills. This is an example where I made sure to look at how we could use other staff. So once again, not just what the therapist will do, but what will our BH staff do? If you have a BH team or a tech team that's also involved in leading groups, that would be a good way to include them as part of interventions. In our residential levels of care, our BHs and some facilities lead groups, and a lot of other facilities, they do the vital signs. So for example, if I have a patient who's struggling with high blood pressure, I could include the BH for interventions because the BH is going to assist in taking the vitals or things like that. Some of our facilities, we have self-medication and the BH monitors that. So that's another way to work the BH team into assisting the client, for example, with taking medication on time or adhering to the medication protocol. So once again, making it the plan multidisciplinary. The therapist isn't the only one that's assisting the client with achieving their goals. In fact, as I always point out, our BHs are with our patients more than we are. There are ears and eyes of also what's going on in the facility. So making sure that we incorporate them into our treatment team meetings. If your BHs are not in your treatment team meetings, sorry, but you're not doing your meeting justice. Making sure they are a part of that multidisciplinary treatment plan as well. So hopefully this can be of assistance to you guys. Just kind of looking at how some of the interventions are written. I just saw, how do you manage keeping up with paperwork without having it be too distracting during treatment? Do you use your computer during sessions or just take notes on a notepad? Very good question. Timely paperwork is always an issue in the clinical world. That is actually part of our auditing our quality process. So as a part of our quality process, we actually audit for two areas. We audit for completion and timeliness, and then we audit for content. So in completion and timeliness, we're auditing for, is it completed? Is it in the chart? Was it completed timely? And then the content session, those documents that are in the chart, what does the quality look like? What does the content, what does the thoroughness look like? And I know you didn't ask for that piece, but I'm just pointing that out because completion and timeliness is highly stressed at each facility level. So our directors are constantly paying attention to caseload and what does that look like? All of our facilities have not gotten to the point where they're documenting in the computer during the sessions. I think we have one or two that are experimenting with that. But right now, usually they're just taking notes and then they're coming back and putting them in the EMR afterwards. We actually changed our progress note to try to make it a little more user-friendly. So a lot of it is chosen options you can click But then there's a portion of it where we leave space for also you to write a little bit of detail. So we've changed it where it's not so much free form, trying to make sure that it's not so overwhelming. But the things that we want to make sure are in the note, we've scripted the note, we've prompted the note. A lot of it, again, is check boxes. And then we have a little portion where we're to write a little bit of the session to make sure that we include how the client responded to the interventions that were used. So hopefully that helps a little bit. As you see, we've been doing a lot of restructuring as to how things are in our EMR so that they can not only be user-friendly to the patient, but also user-friendly to our team, because our team is our number one resource. And so we want to make sure that we take care of them as well. I'm going to pull over KeyPoo, which is our EMR. And we are in a test patient. And so here, this is how our new bio looks once we pull it over. Here's an example of language, because we're like, well, how would you feel if you were a client and if your provider just came in and just sat down and just started asking you tons of questions and tons of personal questions? It's like, we need an intro to our bio. Some people are good themselves at words, and we're probably already doing this, but we did not want to take it for granted. And then we also wanted to make sure that we had fillers and prompts so that our new clinicians would know how we wanted the bio to flow. So here's our little intro. We will be completing a biopsychosocial assessment. It will ask questions about you and different aspects of your life. These questions will range from childhood experiences, medical, substance use, mental health, to your strengths and needs. You may find some of these questions very personal, so please answer to the extent you are comfortable. While we want to collect as much information about you as we can, your safety and well-being take priority. To me, that says a lot. If I'm nervous or mad, I don't want to be in treatment, and I get that type of intro, and we've told our people you don't have to use it word for word, but just make sure that this is the type of language and this is the type of message that you're giving them. That right there just automatically takes away some of my anger and some of my concern. And it's letting me know once I get to the trauma session, if I don't want to answer those questions, we can come back to that later. And so that type of language is throughout here quite a bit. You know, we're getting into a sensitive area. If you don't like what, if you don't want to share right now, you know, we can get that information later. And so some of this is regular bio, a lot of it is regular bio stuff. We've just included a lot of prompts, details of admission, and then we get into the bio part. And we actually kind of put it bio, psycho, then social. So bio, all the stuff that relates to the biological part, and then psycho, all the stuff that relates to the psychological part, and then social part as well. It looks pretty long here, and it actually is pretty long. But once you get used to it and get in the flow, then it's not as bad. Substance use portion, how they acquire their substances. We ask about withdrawal symptoms, overdose history, tolerance questions, and then we get into the psychological. We want to know how they would describe their current mental health status. And what you see here, this is what we call ghost text. And so these are prompts that we're including for the user, for the therapist. Inquire more here. Maybe another way to word the question. We put that into different questions that we found our therapist was just kind of having a hard time getting that particular information. Have you ever thought you may have a mental health disorder? Here, this is our screen for self-harm. We call it non-suicidal self-injury. So we also have a lot of skip logic in our assessment. So for example, if I say no, then nothing happens and I go to the next question. And a lot of areas, if I say yes, then additional information pops up. So this is how our self-harm screen looks. I think this was something that I mentioned earlier that we added just from kind of researching and looking at other self-harm questions and screens. How old were you when you first started to self-harm? In what ways? What areas of the body? How often? When was the last time? Why do you self-harm and how likely are you to self-injure again? And the reason why I'm reading this question out is because we also have a prompt here for our end user that if the client answers a certain way, we better see this on a treatment plan and on a safety plan. So there are prompts like that throughout the bio as well. If this is how they answer, we need a safety plan. If this is a yes, then we want to make sure this is on a safety plan or on a treatment plan. So I wanted to point that out. Prior mental health, we want to know, how did well look for them? So this is also a good question to help with treatment plan development as well. And also a good way to help them gauge process. If they can remember what it looks like when they were well, and we see this type of behavior in treatment, we want to make sure that we're pointing that out to them. Hey, you said that when you're feeling good or when you're well, you usually wake up on time, or you usually do this, or you usually do that. You know, I've seen you do that here lately. So making sure that we point out those things, but also this may be an area that something that the client wants to address on the treatment plan. You know, when I'm well, I reach out to family. And so then maybe that's a goal of theirs, reaching out to family. This is where we included the CSSRS, which is our suicide screen. That's a big chunk of it there. The risk rating. And so the same thing, depending on the risk rating, then we have prompts that, okay, we need to see a safety plan. And then also for those clients who are just entering treatment, well, let me go back. We need to see a safety plan, and we also need to see it on the master treatment plan. But even for the clients who, when they first come into treatment, our nurses are doing one of these as well. And if they're rated at risk, then it's a part of our QA that it must be on that initial treatment plan as well. This is the trauma history. And so as I audit charts, if I'm seeing a lot of yes here, one thing I'm looking for, do we have a history of trauma on that problem list and that treatment plan? The social aspect now. We ask about languages spoken at home simply because family, as I stated, is a big part of what we're trying to do. So if we're going to communicate with the family, do we need to be prepared to have an interpreter? You know, what resources will we need in order to make sure that we are capable to include your family and significant others? They ask about religion, childhood, history with siblings, primary caretaker. This is also a big part of our treatment portion right here, because we're getting into social needs that may be needed. So we start asking about the living situation. If you have a reliable place to live, if I have one today, but I'm worried about losing it in the future. So if I see here that this is shaky, then that needs to be something that's on the treatment plan. How is housing going to look like? Excuse me, where's the client going when they leave our level of care? We even ask about things about food and transportation. If I want to go to IOP after I leave here and I don't have transportation, then that may be a risk. That may be a barrier to treatment. So how are we going to start working on that now as well? Uh, Support system. This is the part that we ask about the support system, who they are, what is their relationship to us, and what type of support. And I'm sorry, I ran past a lot of the different prompts that I wanted to point out One prompt I'm going to go back to, please don't get dizzy as I go back, but this may help the person out who talked about she didn't like the language. This prompt here. So as we transition from one part of the treatment plan to the other, we've included prompts here that let them know, okay, we were just talking about this. Now we're going to talk about something else. And so this right here is a major prompt for us as we go into the trauma section, because we let them know that the next section is specific to trauma and that we understand that traumatic experiences can be tied to behavioral health problems. Many people don't recognize the significant effects of trauma on their lives. So it is important to your treatment that we understand your personal experiences so you can begin to draw the connection between your trauma and your presenting problems. We know this is sensitive information that can be difficult to discuss. Please answer to the best of your ability. Know that your safety and well-being take priority. So once again, pointing that out. And then my favorite sentence here, trauma is defined by you and can be considered as any experience that you deem emotional, disturbing, life-threatening, and or a threat to your safety. Anything you do not feel ready to share now can be disclosed at a later point during your stay. But really pointing out to them that trauma is what you define it as. The same thing that happened to me can happen to you. You can be well with it. I could be devastated and totally traumatized. And so that's the type of language that we've included within our bio, just kind of giving them, excuse me, the permission to feel the way they feel and then to share what they feel comfortable with at that particular moment. As we transition into social, another small prompt, we understand a person's environment can play an important role in who they are and can shape their life experiences. The following questions will allow us to learn about your identity and your experiences and your support system, all the things that make you who you are. So I'm gonna scroll through this really quickly. I think we're down to 15 minutes. Education, financial, all of this is regular stuff that's pretty much on a bio. Military, yes, we get a lot of other information about the branch, if they were deployed. Still, we're kind of asking a little bit about trauma here because maybe this information might prompt us to ask questions about trauma that maybe weren't answered before. Legal history, if they say no, we go on to the next section. If they say yes, then a lot of additional questions about probation and parole, court dates, because if we've got yes, then legal should be on that treatment plan. How are we going to navigate that, especially while you're here in treatment with us? Leisure activities, we want to know what they like to do. We're getting toward the end, so they give us a self-assessment of themselves. Many of times they have a hard time picking out strengths. So just in case they do, we kind of have a list here that we kind of are able to throw up. Well, I heard you mention this earlier. I would say you're pretty brave. Wouldn't you say that as well? So this is kind of more so to help us help them. We don't just read it to them the way it is. This is the part about the barriers that I absolutely love. Internal triggers. We have some prompts here as well as external triggers. And MSC. And then we've also tied our ASAM into our bio. So if we're at a facility that does primary mental health, we're asking, is this particular client, do they have a primary mental health diagnosis or primary substance abuse? And we click yes based on which one they are. If they're primary substance abuse, the ASAM comes up and we flow through it. If they're primary mental health, then our locus comes up and we flow through that. And so that's just kind of a brief walkthrough of the bio. We're really proud of that tool. We spent a lot of time on it. All right. So let me see if we can go through this kind of quickly. I don't want to keep you guys longer than I have you here. But now we're going to quickly talk about the correlation between treatment planning and clinical excellence, operational efficiency, and patient satisfaction. We have a quote here from Aristotle: excellence is never an accident. It is the result of high intention, sincere effort, intelligent direction, skillful execution, and the vision to see obstacles as opportunity. So basically, Aristotle is saying here, we are not going to achieve excellence by chance. We must be very intentional about it and have strategic execution. So first, we talk about how treatment planning relates to clinical excellence. And here we describe clinical excellence in healthcare as the ability to provide consistent, high quality services to our patients. It involves a commitment to continuous improvement, a dedication to the highest standards of practice, and a willingness to go above and beyond to meet the patient needs. So it often looks like just doing the right thing at the right time, in the right way, for the right person, and having the best results possible. Quality healthcare and clinical excellence often means striking the right balance when providing healthcare services by making sure that we avoid overuse. So, for example, doing unnecessary testing, making sure that we avoid underuse. So, for example, missed medications or missed individual sessions or missed groups, and also making sure that we avoid misuse, prescribing the wrong drugs, giving the wrong medication, or describing harmful interactions, prescribing drugs that have harmful interactions, I mean. Healthcare providers can demonstrate clinical excellence by making sure that we're paying attention to what we're doing and that we're being attentive to our patients, that we're correctly diagnosing, and that we're using our clinical skills to deliver the best possible treatment, that we're using teamwork because working in silos does not help us and it doesn't help our patients as well, and that we're constantly engaging in research and educating ourselves. Basically, we're saying that a well-constructed treatment plan is essential for us to be able to provide clinical excellence and quality, because if we have a well-constructed treatment plan, it's going to ensure personalized care, it's going to ensure evidence-based practices, and it's going to ensure that we are continuously monitoring our client for improvement, and that we're continually assessing and making changes as need be. So this is kind of where things begin to kind of sound repetitious because you see how they all link. It's impossible to have one without the other. Now we talk about the link between operational efficiency and treatment planning. Operational efficiency in healthcare involves streamlining processes. So when I first started talking about that bio, I started talking about how we were tired of the redundancy. And if I'm tired of writing the same thing, I know my clients are tired of answering the same thing. So if I put these sets of questions here, then I can remove it from this particular form. Or maybe I can even combine forms and get rid of two separate forms that require two separate workflows for my team. So streamlining processes to maximize productivity, to reduce costs, and to also improve our service delivery. Operational efficiency in treatment planning is essential if we want to deliver high quality healthcare while at the same time optimizing our resources. You guys are our biggest resource. We've got to have you to be able to provide services. So we want to make sure, as I stated earlier, that things are efficient for you as well, so that you can then make sure that they're efficient for your client. So well-developed individualized treatment plans contribute to operational efficiency by, as we've stated, reducing redundancy. If I have a clear structured treatment plan, then hopefully I'm going to prevent unnecessary tests and unnecessary procedures, thus saving a lot of time and saving resources. If I have a clear structured plan, I'm going to ensure that all the healthcare providers are aligned, that we're on the same page, that we're aware of what's on the patient's care plan, thus enhancing teamwork and communication. A well-developed treatment plan also provides a roadmap that's going to help with scheduling. It's going to help with resource allocation and efficient management of the patient flow. So once again, directing and facilitating that workflow. Patient satisfaction is a measure of how well healthcare services meet or exceed patient expectations. So if I have a well-developed, effective treatment plan, it's going to enhance patient satisfaction by increasing engagement. As we know, involving patients in the plan helps foster their ownership and their cooperation and can also improve their adherence to the treatment and overall satisfaction. Provides clarity and reassurance when patients understand their treatment plan and what to expect. This reduces anxiety and uncertainty and enhances outcomes. Personalized and well-monitored treatment plans lead to better health outcomes, which naturally boost patient satisfaction. So we've spent time today defining treatment plans, discussing how to develop effective individualized treatment plans. We then covered the correlation between effective treatment plans and clinical excellence, operational efficiency, and patient satisfaction. So really quickly, I'm going to take about the next 2 to 3 minutes to transition and spend a little bit of time on how we can enhance their outcomes by making operational improvements. So operational improvements look like exactly what we've been talking about, how we went in and we changed our bio, how we looked at some of our workflow. So some ways that you can start looking at your workflows, process mapping. Process mapping is a tool that you can use to analyze what your workflows look like, and it'll help you to identify inefficiencies and bottlenecks and areas for improvement. A lot of times streamlining these processes can reduce delays and errors and lead to improved patient care. There are several types of different process mappings that you can use. Value stream mapping is one. Detailed process mapping, which is where you drill down on a certain process to really see where the gaps are, or just using a basic flow chart, which I have a sample of this on the next screen. And that's where you kind of just visualize a process and what the inputs and outputs are. And then also looking at lean principles. My boss is actually has her lean certification. So every single thing that we do, she's always looking at how can we reduce the amount of times we touch this particular document or this particular process? How can we reduce waste when it comes to our time? How can we reduce patient waste times? How can we improve care coordination? So really taking a lean approach as to where's the waste, whether that be waste of time or waste of other resources, where does that come into play? And this is just an example of a basic process mapping flow chart. I have a link here that you probably might definitely find helpful if you're into this. It talks about the different types of mapping and how to use them. So I'll make sure that that's one of the resources that we share as well. Using those interdisciplinary teams, we've already kind of talked about that, so not going to spend much time there. Making sure we foster collaboration amongst our team. Making sure that those regular team meetings are a priority, and how can we schedule them where everyone is there. And then also looking at your EMR, your health information systems that you use. How can we use that to help make sure that we're interchanging information in a quick and easy manner? Do we have prompts? Do we have signs? Do we have triggers when it comes to communication? And making sure that the other department knows what we need them to know. Performance metrics. Using those outcome measurement tools that we spoke of earlier. Looking at those, making sure we're looking at the cadence in which we're using those and using that data to drive any type of improvement, not only for the clients, but using that data to provide system improvements that we may need to make here as well. Do we have KPIs that our facility has set up? Do we have additional clinical outcomes? Are we looking at things such as our readmission rates, our infection rates? Are we looking at our patient satisfaction scores and reading those comments and letting those things drive our processes as well? And last but not least, here I have root cause analysis, making sure that we're using those to analyze adverse events or near misses. A root cause analysis is a process that we use to help us to look at system failures. It helps us to identify process issues. And then it helps us to proceed with implementing corrective actions so that we can enhance patient safety and quality care. Last but not least, predictive analytics. Use predictive analytics to anticipate patient needs so that we can allocate resources effectively upfront. And then outcome measurements. Measure and analyze our clinical outcomes data to identify trends and areas for operational improvement. This data-driven approach ensures that operational changes are aligned with our patient goals. And that is it, guys. Let me look and see if I have any questions that you guys may be able to stay on in here. Just
Yeah,
in case.
just hop in and say that we can totally go over a bit. But if you're here for CEs, I will end that time at 11. So if you need to go, you're welcome to do that, and you will still get your CE credits if you were here the whole time. But if we want to go over some of these questions, there were some really good ones that came in. If you want to answer a few of those, Jimmies.
Sure.
A reminder, you'll get an email from JotForm with an eval within the next hour. And then if you did not meet the requirements, you will also get an email from Promises by the end of the day. So you'll know either way if you've gotten their credit or not. So if you have any questions, just let me know.
All right. So let's see, how can we use this for discharge planning? Definitely, definitely. Discharge section is one of our quality measurements that we audit for as well. As you know, as clinicians, discharge planning starts at the beginning. So looking at those outcome measurement tools that are completing on day one and seeing how they change. Looking at that biopsychosocial, and for example, the portion that inquired about housing, that inquired about trauma. Well, I know I'm not going to cure my client's trauma when I have them for only 2 to 3 to 4 weeks. So I'm starting to plan at the very beginning based on problems that I've assessed at the very beginning. So the trauma issue on the bio, there was an issue where we talked about other resources. Would you like any additional information on working or on jobs? That was a part of our bio. Well, if so, then that's something that I'm going to make sure that is included within the discharge planning as well. Any other appointments? It is one of our quality metrics that we look at. Does our client have an appointment with their next provider within 7 days of leaving us? So that's another issue at discharge. So starting to schedule those appointments based on those needs, medical needs, psychiatric needs, housing needs, any other case management needs as well. So all of that transitions into discharge planning. There may be some goals that I wasn't able to complete when I was in residential care, but I want to continue working on, or that I want to make sure that I maybe get a referral to upon completion. So it all ties in, but the earlier you start, the better. What does treatment planning and team look like in a private practice setting? That's a very good question. I actually do a little bit of private practice with a colleague of mine on some evenings. And so quite often our treatment team will look like us consulting with each other. It's her business, and I just kind of came on as an adjunct therapist. And so sometimes she may feel like I'm a better fit for a particular couple, or maybe I feel like she's a better fit, but we will get together and discuss cases, especially if we're having difficulty with cases. But also it will look like if I know that my client is seeing an outside doctor or an outside provider, or is getting or is prescribed meds from someone else. then making sure that I've talked about getting an ROI with this particular patient and I'm able to consult with that doctor if need be. A lot of times it also looks like consulting with maybe not only the colleague that I work with, but maybe an overseeing supervisor that I have. And I want to get better information or another therapist idea about interventions that I'm thinking of. But yeah, we definitely don't want to we want to make sure that although private practice, that we're not doing that in a silo either, but that we also have people that we can consult with and that we're also getting ROIs in place for additional providers that we may need to consult with that are currently assisting our patient. What would the discharge planning look like as far as continuous treatment planning? I think I've kind of answered that a little bit. Just curious, how long are y'all given to complete the treatment plan? 72 hours from the time of admission is when that master treatment plan is to be completed. The initial treatment plan is to be done within 24 hours. That initial treatment plan, the purpose of that is just to address stabilization and safety. So really needed for those who are coming into detox as well. We're talking about stabilization, but then also safety. So if there's a risk level that comes up on that suicide screening at the beginning, that definitely needs to be on that initial treatment plan. So initial treatment plan, stabilization and safety, 24 hours, master treatment plan, 72 hours. What's the duration for which a treatment plan remains effective before requiring a revision? We require that treatment plans are reviewed weekly. And so reviewed, basically, we're looking at it, we're seeing if what's on the treatment plan still applies. It may not need to be changed, or it may need to be changed. If it does, then great, we change and update it. If it doesn't, then we make note that it has been reviewed, interventions are going to remain as they are, and then we proceed with the plan written as is. How long is intake using your customized biopsychosocial? I love that question because I was so worried that our team would be like, oh my God, what have y'all done? And who do you think has time to do all of this? So that was really a fear of mine up front. And to our surprise, they loved the bio. It did eliminate some other forms. So that was a win-win. Although it looks longer, hey, it looks longer because now you don't have to go do this other form. But a lot of the team really, although longer, was really impressed with the questions, the wording, and the language. I tend to be slow. So if I'm the one completing that bio, it's probably going to take at least an hour to an hour and a half for me to complete that bio with the patient. And so at that time, you may need to give the patient a break. You may need to break it up a little bit, just depending on your setting and how things look, but really being aware of how long it takes you to do certain things, just kind of being aware of your own level of functioning. But yeah, I'm slow, so that takes me a little while. If longer than the scheduled time, how do you develop your treatment plan if it's required after your first session? So that treatment plan is required within 72 hours of admission. All right, those are all the questions that I have. Thank you so much for your time and attention today, guys. Thank you so much for your assistance, Callie. Really appreciate you. And hope to see you guys on more Promises webinars. Enjoy your Friday, enjoy your weekend, and take care, guys.
Have a great weekend. See you all in 2 weeks. Thank you.
Bye-bye.